Hi, good evening, everyone, and welcome to this webinar on the importance of point-of-care ultrasound in MSK assessment. This evening, we are delighted to be joined by Sports and Exercise Medicine, Dr. Marwan Al-Dawood, who will deliver a short presentation followed by questions and answers. We do have some pre-submitted questions to get through, but if you are watching live, please put any questions you have in the question and answer section, and we can get round to addressing those too. So with that, I'll hand you over to Marwan to get started.
Thanks, Louise, and thanks everyone for giving up your Monday evening to listen to me talk about Hocus Pocus. So I'm going to just give a little bit of introduction about who I am. So I'm a sports and exercise medicine doctor. I'm also a GP. I work in pretty much the whole healthcare landscape. So I work in primary care, community musculoskeletal medicine. I work also as part of a hospital NHS trust, elite sport, private practice, and I'm also involved in management. And I do sometimes sleep. So I'm pretty busy, but yeah, I kind of cover most aspects of the healthcare landscape in my kind of working week. I've worked for quite a lot of different organizations over the years. Some of those on the screen I still work for, some I do consultancy for. So yeah, I've worked in a lot of different sports, from rugby to football to athletics, ballet. So a fair range of sports, and also more community MSK and musculoskeletal services. So a bit of an overview of what I'm going to talk about tonight. So I'm going to talk a little bit about what does it take to be a point of care ultrasound clinician. I'm going to talk a bit about the machine and whether that makes a difference. A little bit a nod to X-rays and MRIs. And I know that there were some of the preset questions were specifically asking about using kind of ultrasound in conjunction with different imaging modalities. So I'm going to talk about a bit about that as well. And then finally, I'm going to talk you through some cases. So Louise is asked me to try and keep this within about 15, 20 minutes to allow plenty of time for Q&A. So I've probably got about 100 cases that I could put on, but I've tried to dwindle it down to 5, which I thought would be the most kind of pertinent to talk through. So a little bit about training. So there's lots of different places you can go to get trained in ultrasound. There are lots of formal courses that have a qualification at the end of it. You can get a certificate, you can get a diploma, you can go on to masters, etc., etc. So there are different levels. Essentially, the good ones, and the one you want to be doing, is one that's CASE accredited. So that's kind of the accreditation system for ultrasound. I've got a bit of bias in that I do kind of work for and faculty for the Bournemouth one, which is AECC there. That's the one that I did. And then since then, I've been teaching and have students from there. But they're all good courses. And those are just the 3 ones when you type in Google that come up first. There are lots of other ones. Doing all that. So when you learn to scan, it's a bit like passing your driving test. So you have to learn all the theory, you have to learn all the practice, you go do your assessment, you have to submit a logbook. When you get your piece of paper at the end of it, I take that as being the time when you pass your driving test. Clearly there's after you pass your driving test, you're not really ready to go on the road. And that's probably similar with ultrasound. So there's a few things you need to do to try to get yourself kind of that next level of kind of development within your ultrasound. So the first thing is to find a mentor. They're difficult to find mentors, probably because the system isn't really that joined up. So some courses do provide mentorship. A lot of courses just expect you to find one. And because a lot of people are going kind of privately and self-funding these courses, and then most of the healthcare sector is NHS, it can be quite difficult to find someone who's either got time, space, or hasn't already got kind of trainees on the NHS to mentor you. So if you're lucky, you can find a good mentor. And I think the other thing is to get regular practice in clinic. So if you're going to go on a course and learn to scan, but you don't have access to a scanner either at home or in clinic, then you're not going to have a chance to really practice that skill, and quite quickly you'll de-skill. Conversely, if you do have a scanner, so I remember when I was learning, I was working at a rugby club at the time, and there was a little portable ultrasound scanner, like the laptop one, and I just took it home with me for a month in between clinics, and I'd scan all my family members about 1 million times, and that way I kind of got just practice of doing it. And at the time, I also had access to an ultrasound scanner in the clinic, the MSK clinic I was at. So even though I just passed the course and I wasn't really ready to independently scan, I did still scan everyone. And it was quite good for me because I could scan and then I could send them for a formal scan and then compare my scan findings versus the actual proper report findings. So moving on to the machine. So there are lots of different machines you can get. There are cart-based systems, there are laptops, and there are handheld devices. So they all have different strengths and weaknesses, and they all have different uses depending on what you need them for. I think in terms of the highest quality machine is clearly going to be a cart-based system. And it's just like imagine a laptop versus a PC or a big Mac. You're not going to get as powerful processor, as much RAM, etc. in a laptop versus a cart-based, and similarly with a handheld. But it just depends on what you're using it for. So I used and use all of these systems in my practice. So I've got a handheld one for whenever I'm going on like a trip with a sports team. So if I'm going abroad, or I just want something that's there to just help me kind of pitch side or in the dressing room, that can be useful. I'd probably say your handheld ones are quite limited, but there's a few good ones in the market, but they are bang for your buck. They're quite expensive compared to something like a laptop one or even some of the cart-based systems. The laptop ones are probably, they're probably like the most versatile in that they can be quite good quality and they're mobile. So if you've got a need to move your scanner from clinic to clinic, then having a laptop one is good. So if you're in like different clinic each day, or you work for different organizations and you're thinking of purchasing one for yourself personally, then a laptop can be useful. But if you're purchasing a machine or you're using a machine that is fixed in a certain location, it's not going to move, and you're there regularly, then yeah, we're definitely saying to get a cart-based system. So as I say, they've all got strengths and weaknesses. In terms of other scans, so this is like getting into a bit of the meaty stuff. So the X-rays, ultrasound, MRI, they're all completely different modalities, and not one is stronger than the other. They're just different types of modalities, and they've got different uses depending on what you want to use them for. So I put up here some kind of comparisons. Now, this is by no means completely exhaustive, but I've put in basic terms what X-rays are good for. So X-rays are very good at looking at degenerative conditions for arthritis. They're good at looking for fractures or any bony pathology. And they do show up some of the calcifications or hardening that you can get in soft tissues, such as enthesiophytes, spurs, calcifications, etc. Ultrasound is good for soft tissue, any soft tissue problem. Ultrasound is very, very good. It's good for tendinopathy. Some of the advantages over MRI in tendinopathy with some tendons, such as the patella and Achilles, is that you get neovascularization. So you can put Doppler flow on and you can see whether there's vascularity within that tendon, which you can't get on MRI. So you do get different views and different kind of strengths and weaknesses. Ultrasound is also really sensitive for bursitis and also enthesitis. So enthesitis would be, for example, if someone's got bilateral heel pain and clinically you think it's an insertional Achilles tendinopathy, you put your ultrasound probe on and there's loads and loads of vascularity and thickening, etc. That's an enthesitis, and that's a rheumatological kind of red flag. So it is very good at picking those up, and realistically you don't see them in other modalities as readily. For arthritis, you can pick up arthritis on ultrasound. And I remember when I first started to scan, picking up loads of stuff and thinking everyone has arthritis because it's really, really sensitive. So you do pick up lots of things that wouldn't show up on an X-ray and sometimes not even on an MRI. So a really classical one would be like the humeral head or the AC joint, or the midfoot of the midfoot bones. You can pick up with ultrasound really, really tiny little bits, tiny different differences in contours of the bones. So you almost get this kind of subclinical scan, essentially. Does that mean that you overdiagnose arthritis? It depends on your interpretation, and it might give you an answer to why they're getting pain, but something that wouldn't traditionally show up on an X-ray and you wouldn't be able to explain. Calcifications, it can pick up early, late as well. It's good at picking up. So for example, in the shoulder, you can pick up calcifications in the cuff when they're very early. So we know that calcifications start off generally soft. They then tend to harden up. So when they're quite soft, they don't tend to show up that well on an X-ray, but they do on ultrasound. So MRI, I generally tend to, again, it depends on where you're coming from. So if you're working in professional sport versus working in MSK, in the NHS, they're very different clientele, very different needs, very different cultures of what scans are used for what. In sport, MRIs are used massively. I think sometimes they're used too much, whereas ultrasound could be useful. But MRIs are very good. I think in an MSK setting, MRIs are good for when you're thinking of referring on to orthopedics, if you're thinking pre-surgical, if you're thinking something intra-articular, such as the hip, shoulder, knee, clearly MRI scan is great for that. I mean, I put their spine, there's a bit of it, it depends on what problem in the spine. In terms of comparing it to ultrasound, some of the deep tendons are better viewed on ultrasound, such as the proximal hamstring tendon. Again, that depends on the patient in front of you, so their body habitus. So someone who's very slim versus someone who's large, the ultrasound might struggle to penetrate into deeper tissue, and that's where MRI might be better. Hamstring is a really interesting one, and in my next slide, I'm going to talk a little bit about hamstring, because that's probably, I think, the big one. For those of you who are working in sport, that's the big one, I think, where it's interesting to talk about how MRI and ultrasound compare, especially with stuff like the BAMIC classification and things like that. In terms of some of the pros and cons, so X-rays, they're quick, cheap, not very operator dependent, but they give you a static image, and obviously they don't show up any soft tissue generally. Ultrasound, probably the biggest strength in that it's dynamic, so you can move stuff as you go along. So if you're wanting to stress a tendon or a muscle, you can do that. If you're wanting to check a ligament, check for laxity, you can do that dynamically while scanning. For example, looking at the UCL of the thumb or the ATFL, you can do it while scanning, so you can see whether there's movement, if there's fluid. Another one would be scapholunate ligament. There's lots of dynamic stuff you can do with an ultrasound. It's very sensitive, but the one big drawback of it, which is a pro and a con, is that it's very operator dependent. So that it's useful for those of you who are working in musculoskeletal services for the general public, such as the NHS, that then you send ultrasounds requests and they're done by somebody else, and then you get a report. I think that's probably highlights the importance of getting to understand and know the person, that the people that scan and the people that report in your area. So if you if you looked at the spectrum of an MSK radiologist, a general radiologist, an MSK sonographer, and a general sonographer, your reporting from an MSK radiologist or MSK sonographer is going to be much higher quality, most likely, than a generalist radiologist or a sonographer. So it is worthwhile understanding what you've got in your dynamic in your area. In terms of MRI, they're more expensive generally. Particularly in the public sector, there's a waiting list to get one. You could argue that there's a waiting list to get an ultrasound or an X-ray, but we're talking about point of care ultrasound where you can do it there and then. Clearly, the MRI scan is very detailed, so it gives you lots of information. So in terms of hamstrings, this is a case of a professional rugby player that I saw last week. So for those of you who don't know what that looks like, so that's a cross-section of their hamstring. In terms of anatomy, just forgive my little squiggles. I mean, I did this on my phone, so it's using my big fat fingers. But you've got the long head and the short head of the biceps femoris, and that red T is the T junction, which is quite a critical area. So this player had a T junction tear, which I've highlighted is in that red line just there. So in terms of what it looked like, if you just compare it to where I remove all the diagrams, you can see there's a bit of black essentially in that T where that should be, and that's the length of the tear. And when we compare that to the ultrasound of this patient, so that's the ultrasound comparable in terms of anatomy. So similarly, you've got the long head, the short head, and the T that's there, and then that's the tear. So I just remove it, and you can compare it like with like. So in this scenario, there is a really good correlation between MRI and ultrasound. One of the things that that you need to be mindful of with MRI is this, which essentially, hopefully you can see my cursor wiggling around here, but essentially ignore this little X, that's the radiologist kind of highlighting an area, but essentially this bit here, this white stuff here is where you've then got edema. So obviously when you get a tear, you get bleeding, and then you get swelling, and this shows up as bright white. Now, sometimes the edema or the bleeding, well, not sometimes, all the time, it tracks down. So you might have a tear at point A, and then you have edema tracking down to point B, but the tear doesn't come down to point B. So that's why sometimes, and it depends on the radiologist, and that's probably why it's a good idea to have a good working relationship with the radiologist, because a good radiologist will report as per BAMIC classification. But in general, that's why sometimes you tend to find, this is my experience in working in professional sport, is that sometimes MRIs they almost overcall it. So you get these, you get a tear that's graded like a 2C or a 3B or something, and you gut feel clinically is that it's not that kind of tear, and then when you look at ultrasound, it can be smaller. So it's a bit difficult, and I think the BAMIC classification is really good to help to classify all that stuff, but sometimes it can be overreported. I never really tend to find MRI scans being underreported. They generally tend to be bob on, or sometimes just overplay it a little bit. So that is worthwhile, and that's why ultrasound can come into play. Before I go on to cases, I'm going to show a little video. So I'm going to try and sort this out. I did try to embed the video onto into this PowerPoint, but it came out really bad quality. So I'm going to stop sharing. Hopefully this is going to work. And then what I'm going to do is reshare the video, and hopefully it works. So essentially with this patient, I did a PRP injection. The reason why I wanted to show it is because I think there were some questions about PRP. Is that, it says it's loading. I think that should be working now. If it's not, just let me know, Louise. So this video, so you know the anatomy. So in terms of the PRP injection, so the needle's coming in from the left up here. So you can see it going into that kind of T-junction, into the kind of main body of the tear. And then now you can see that's when I'm starting to deposit the PRP into the tear. And you'll see this little bit start to expand a tiny little bit. Just there underneath, and I go back a bit, put a bit more in, and you can see it going in there. And then that's the end of it. That was only about 2 mils of PRP, so it's quite small. Right, let me just re-share back to my slideshow, which is now decided to disappear. Right, I think we're back on. Here we go. So hopefully that was a bit useful. As I say, there was some questions about PRP, and I'm more than happy to answer them, other ones if there are afterwards. So moving on to the meaty bit, I'm mindful I'm going over a little bit, but I've got 5 cases here that I wanted to go through. So I've purposefully not put any clinical examination findings on any of these cases, and I've done that because because I think almost you putting the clinical examination findings with the ultrasound makes it really easy. So presenting it without the examination findings, it already is easy, but presenting it with it just makes it too easy. I'm trying to illustrate the point that when you do a history and examine and scan, it's really, really powerful. So this was a case, and these are all cases obviously that I've seen and everything. So this was a case of a 52-year-old manual worker who 9 weeks ago slipped on the ice and fell onto his left elbow. He felt his shoulder jam up and immediately had pain, and that's persisted. A few days later, he went to A&E and he saw a really experienced APP who organised an X-ray, which was normal, and then he referred him to community physio. Somehow the patient then went to see a FCP in his general practice, in his GP practice, who assessed him, thought he had subacromial rotator cuff related pain, gave him some exercises and referred him to MSK for a steroid injection. So when I saw him, as I say, I'm not giving you the examination findings because it gives it away, but this is the ultrasound findings. So in terms of those of you who aren't au fait with the anatomy, that's a bit of a sketch of the anatomy. So you've got the humeral head in blue, you've got the long head of biceps in red, there's an effusion around the long head of biceps in yellow. And in this kind of case, an effusion around the long head of biceps generally is not because there's a tendinopathy of the biceps. In the kind of scenario of trauma, it's generally because there's either an intra-articular problem and then there's fluid tracking down the long head of biceps, or there's a cuff problem and then there's like a tear, and then that then comes to the rotator interval, and then you get it in the long head of biceps, or both. And then on top there, you've got the anterior deltoid. So if I just go back, so you can see that ring of black around the long head of biceps, and that's the effusion. And again, just I haven't really clarified, the long head of bicep, that's like a short view of the long head of bicep. So it's if it's coming out towards us. The next view, so this is the kind of supraspinatus view. Again, from an anatomy point of view, you've got the humeral head. There's a bit irregular, the humeral head. There's a deltoid, the anterior deltoid, and then you've got the kind of subacromial space. Now, if I go back, you can't clearly see the supraspinatus tendon. That's because it's not there, because he's torn it. And what you can see that supports that as well is that you've got fluid here. It's just running. This is the bursa. So you've got fluid that's pulled, and this is kind of medial. So the coracoid would be kind of this zone here. So you've got fluid that's pulling, kind of medial aspect of the bursa. And then if I go, what I've then done is gone laterally onto it. So then this is now the humerus, deltoid, and the bursa. And what this is here, this is what's called a teardrop sign. So we know that the bursa it comes over the top and essentially extends down to the humerus, and it comes a lot lower than you expect. Now, if there's a tear in the cuff and you have a big bursitis, because of gravity, what tends to happen is you get the fluid that pulls here. Now, sometimes it looks really crisp and clear. This one, it looks a bit messy, and that's probably because there's probably a part of retracted tendon all in this space here as well. So it's all a bit of a mess, really. So he's got this positive teardrop sign. So I diagnosed him with a rotator cuff rupture and a suspected labral tear, and I referred him urgently to orthopedics. Obviously, he's 9 weeks old. If the first clinician who saw him had point-of-care ultrasound, he probably would have got diagnosed straight away and would have had a better chance of having a repair. The next case is of a knee. So it's a 65-year-old retired nurse. She's had 4 months of medial knee pain, which started off relatively quickly. She saw her GP, who gave her some naproxen and referred her to physiotherapy. She had some sessions, wasn't improving, so an X-ray was organised, which showed early degenerative changes in the medial compartment. She was then referred to MSK, and then the MSK clinician who first saw her did an intra-articular steroid injection, which didn't help, and then she was referred on. In terms of what you see, that's the scan of her medial knee. So for those of you who don't know the anatomy, so you've got the skin at the top, and then you've got the medial femoral condyle here, where there's a bit of an osteophyte here, the tibia, and then this triangle's the meniscus, the yellow triangle's the meniscus, and here you've got a parameniscal cyst. Now, she was very tender over the parameniscal cyst, and those of you who, again, it's in terms of what could be done. So I aspirated the meniscal cyst, and this is what I got from it. So I managed to drain the meniscal cyst. Now, in terms of, this is a bit more grey in terms of whether this really made a difference. We know that parameniscal cysts are generally there because of an underlying degenerative process. But for this lady, interestingly, she had immediate relief. I didn't put any steroid in. I then reviewed her 6 weeks later, and her symptoms had improved a lot. Then the meniscal cyst had recurred, but her symptoms had improved. So I just left things open. And I think for her, the pain she could manage, it was more to do with really not knowing. And I think one of the things that threw her is that because the X-ray mentioned arthritis, total knee replacement was mentioned, and that's what worried her. So I think knowing that actually it was a much more manageable problem, I think made it easier for her. So again, I think that's something where that was something of use. This is a good one. Those of you who follow me on Twitter would have seen this one. So this is an 86-year-old man who 6 months ago, getting out of a car, had a sharp pain in his groin. He presented to primary care. He's got a background of polymyalgia rheumatica, so he's got a long history of oral steroids. So quite rightfully so, an X-ray was organised to exclude a fracture. The X-ray didn't show a fracture, but it was reported as having bilateral early osteoarthritis, so it was referred to MSK. When they came into MSK, they saw a physio, gave some exercises. They weren't getting any better, so they were considering referring them to orthopedics for a total hip replacement. But with the system they have like a supervision structure where in one of the places I worked, the case was discussed with an APP for a senior review. They reviewed them, organised an MRI scan. The MRI scan reported early OA and an adductor tendinopathy. So they referred back to physio, some adductor rehab, and then they weren't improving. And then they were sent on to SEM, to me, for consideration of an adductor tendon intervention. So when I scanned him, And again, I'm not going to say the history because it kind of gives it away, or in terms of the examination findings, but essentially this is a scan of the inguinal region. When I got him to do a Valsalva remover, so to increase his intra-abdominal pressure by, it's a bit like when you pop your ears, when you blow your nose and pop your ears, that's kind of increasing your pressure. When I got him through that, this was what happened. So a bit of bowel came out of the inguinal ring. So he had an inguinal hernia, and I referred him to a surgeon who repaired it. He got better. So it's probably a good case of how the journey can be so convoluted when this was never even an MSK problem in the first place. Fourth case is a 26-year-old professional rugby player who's 6 months. He's got a 6-month history of medial ankle pain radiating distally to his medial midfoot. So I'm not going to give you any other history than just that. From a scan point of view, this is what we found. So I've labeled some of the stuff there. So he's got his FHL and his FDL and his tib post tendon. And for those of you who can't see, there's a bony fragment that's just there. So in terms of the other bits, this is the medial malleolus, and this is this bony fragment that's there. He was very tender over the bony fragment. So we organised an MRI scan, and the fragment shows up in blue. And there's a bit of kind of edema in the bone, but essentially the irregularity is in blue. Just put up here the report. Excuse me. Just whilst you're reading that, it's interesting that it mentions that it abuts the tibial neurovascular bundle, and he did present with that medial pain radiating down to his foot. So just to highlight what the neurovascular bundle is, so this is the neurovascular bundle here. So you can see that it's very close to this. Now, on ultrasound, this looks like it's a million miles away, but if you look, this actually only measures, this fragment measures just over 0.5 centimetre, but it looks massive on here. So the distance between this bone and here is a few millimetres. And you can imagine when moving, that would potentially irritate it and cause the symptoms. So what did I do? Refer to orthopedics, and then that was surgically removed, and then he was flying. Last case, so it's a 35-year-old lady who had a notice of lump, dorsal aspect of the wrist, dominant hand. It was impacting on her work as a secretary and her daily life because it was causing compressive symptoms. It looked like a ganglion. The GP thought it was ganglion, so referred it to MSK to look to either aspirate it, excise it, or whatever. And this is what we saw. So the reason why this is probably quite grainy is because I was using the hockey stick probe for this one, so it's quite zoomed in. But I put the different layers that are here. So essentially what we're looking at is this oval structure here, and this represents a sebaceous cyst. So you can see you've got the skin layer, you've got the subcutaneous layer, you've got tendons and all the other stuff underneath. So ganglions don't tend to look like this. They tend to come from either the joint or from the tendons, and they generally tend to be fluid filled. But this was a cyst, this was a sebaceous cyst. So I referred the patient to dermatology, and it was excised, and it was a sebaceous cyst. So I've gone way over my 15 minutes. Sorry, Katie and Louise. But in summary, using point-of-care ultrasound coupled with a good history and clinical examination, in my opinion, is unrivaled. I think it's almost like taking a history but not examining, or just examining, not taking a history. Using an ultrasound to then, you've taken a history, you've got an idea what you think's happening, you've got a hypothesis, you examine them to kind of test that hypothesis, and then you scan them to prove that hypothesis. And if you're not sure, I've shown that you can use other modalities to support you as well. It is really important to get good training, but also with that to get experience and mentorship, because if you just go on a course and learn to scan, that in itself won't make you a great sonographer. You need the experience and the supervision for someone who's experienced and to help you. And we've also looked at how POCUS can complement other investigations such as MRI and X-ray. Thank you. I'll open up. I'll hand back to Louise to help with the Q&A.
Thanks, Marwan. Can you see me and hear me?
Yep. I'll stop sharing. Shall I stop sharing the screen?
It's completely up to you. It doesn't matter. So thank you so much. That was great. I'm sure our viewers will agree with that. So following on, I thought it would be great to go into some of the pre-submitted questions. So we do have quite a few submitted questions, which is great. Some you may have some information you may have already covered in your presentation, but again, we can skip over them, but I would like to go through them if that's okay with you.
Yeah, of course.
Okay, so the first one, so does point of care ultrasound negate need for MRI, CT? As if you do use point of care ultrasound, wouldn't you end up getting an MRI afterwards, or does point of care ultrasound add?
Yep. So I'm assuming that's the question is about private practice or in sport. Is that what it says?
Just bear with me a second. I'll be able to see. It's actually from a medical student. So.
Okay. So that's probably a question that's probably more applicable to private sector and elite sport, because in the NHS, the waiting list to get some of this stuff is big, and point of care ultrasound. I mean, at the end of the day, if someone needs a different scan, they need a different scan. But certainly not everything is an MRI, and not everything is an X-ray. So examples of things that are better for ultrasound than MRI. So I mentioned the tendons such as patella tendon and Achilles tendon. You get a lot more information from an ultrasound on a proximal patella tendon and an Achilles tendon compared to an MRI scan. For those of you who see MRI scans, those tendons come up really small and you get little shiny bits and bright bits. Whereas on ultrasound, you can really look at the fibers, you can look at the thickness, you can look to see if there's neovascularization there. You can then move that tendon dynamically. So you can do loads of stuff to kind of, from an ultrasound perspective. In terms of the shoulder, so again, the shoulder, if someone's got a rotator cuff tear or a subacromial bursitis, you don't need an MRI scan to disprove or prove those things. Ultrasound is the modality of choice for rotator cuff stuff. For the shoulder, you need an MRI scan if you're thinking something's happening like intra-articular, such as a labral tear or some sort of bony issue in the joint, but it doesn't give you that much more. As I say, if anything, with the shoulder, you can move the shoulder in different directions and things, so you can get more from the shoulder via ultrasound. The ones where it's probably more contentious would be ligaments. So, for example, an MCL tear of the knee, you can pick them up on ultrasound, but MRI tends to be better. We talked about the soft tissue stuff, such as hamstrings, calf tears. Again, you can, in the right hands, you can pick them up very well on ultrasound, but the classification systems are generally made for MRI rather than ultrasound. So, yeah, there's probably certainly if the question's coming along the lines of everyone needs an MRI scan, then that's not correct. That everyone, even in elite sport, not everyone needs an MRI scan for everything. And that's one of the things I tend to find, actually, that often that MRI scans are way over requested from some sports teams, whereas sometimes even an X-ray would be more beneficial. So, for example, even things like acute fractures and things, sometimes it's MRI straight away, but X-ray can be just as useful for some conditions. So, yeah, MRI definitely isn't the be-all and end-all.
Great, thank you. So moving on, so we have a GP. It's actually interested to hear about what has helped you improve your point of care ultrasound skills, and mostly what you wish you knew before you started.
So going on a good course. So I mean the courses are all, at the end of the day, if you go on a course, they're all going to teach you stuff, but it's then finding a good mentor, so someone that is going to give you some time. So having a good mentor is really important. Having experience, I mentioned it in the talk, in terms of having access to a scanner. I think if you don't have access to, it's like anything, if you can't practice it, you're not going to get good at it. So you need the opportunity to practice. And sitting in with a radiologist once a month for half a day and then letting you do your case here and there, you're not going to get massive volumes of practice. You might get good supervision, but you won't get good practice. So you need to get lots of practice, lots of supervision. That is very difficult to do. And, loads of people who go on courses, I get contacted a lot for people wanting like supervision and mentorship, and there's just not enough mentors who have the time. I think probably a little bit of advice I'd give would be to buddy up with, make friends with guys such as yourselves, like Louise, who basically distribute the scanners, because, having a relationship with the distributors can be really helpful, and it's useful to know, to have a relationship with them, because they can help. They could maybe lend you a scanner. I'm not saying you're going to lend everyone a scanner, Louise, but as in, I've been in a position where, you might be able to borrow one for a little bit, try one out. You get, having a good relationship with the distributors, I think, is helpful as well.
Thank you. Okay, so moving on to the next one. So for moderate to severe knee osteoarthritis, how many times you recommend PRP in a year?
Right. Well, that needs unpicking, does that question. So there's probably two different strands to this answer. The first strand is that, taking a step back, osteoarthritis of the knee is the primary kind of treatment for it is patient education and self-management with home exercises and exercise advice. That's the prime treatment for most people with osteoarthritis. And the reason why I'm saying that and laboring that point is that as someone who does a lot of interventions, often I get asked to do interventions of patients who haven't even had that at all. So what we don't ever want to be in is a position where we're just injecting people with whatever it is, whether it's steroid or PRP or anything else. Just injecting regularly into patients' knees is not a good idea, because it creates over-reliance on medical system. It creates kind of over-medicalization of issues which can be self-managed. Those patients who do need more. So interestingly, there's a big systematic review, meta-analysis published a couple of months ago, and this might be what the person might have is alluding to, which looked at PRP for osteoarthritis, and actually that it was very, very favourable to give PRP. PRP in the NICE guidelines, which is obviously the guidelines that helps guide the NHS and healthcare staff, that the PRP is actually part of NICE guidelines for osteoarthritis of the knee. So it definitely seems to have evidence that it's there. I wouldn't really, in terms of, I don't think I'd really get into a kind of how many a year type stuff. I mean, how many PRPs you do, I think is probably equally financially driven by the people who advocate it, as along with some of the evidence. So I'd probably just take it with a pinch of salt. The only thing I would say, again, just to add, is steroid, which is much more common in the knee, which is used particularly in community and primary care loads and too much. If you just go over the pond, so America and Australia, steroid for the knees came out of fashion a long time ago, and they have moved to biologics such as PRP, etc. So it's not like they just removed any injection, but steroid, yeah, I've definitely tried to move away from steroid, but it's very much still there in the NHS landscape of just injecting people's knees with steroid all the time, which I don't think is the best practice.
Yeah, I genuinely feel like we could have a whole webinar just on that with a specific interest in PRP myself and my background. Yeah, I'm itching to talk, but I'm not gonna. So moving on. Okay, so have you found a big difference in MRI reports and dynamic ultrasound?
It's interesting to get yes, and I think I did allude to this in my talk, which is it does depend on the radiologist, and it depends on two things. It depends on the quality of the scanner, the sonographer, so that's you, it depends on your level of skill and experience, and it also depends on the radiologist's level of skill and experience. Just in that case, which I put up of the hamstrings, so that case was reported by a really experienced MSK radiologist, and it matched up exactly. Sometimes it does, sometimes it doesn't. Sometimes, and this is really common, and I think there's a few sports doctors and sports physio I've seen in the kind of delegates list and stuff. Sometimes you've got the MRI scan and it comes back at something and it's like it's a bit unexpected, and you think clinically it's nowhere near this bad and stuff. And sometimes that's when you kind of mix between using the scan kind of what's the word, in its essence, versus using it. I mean, the word I'm trying to think of is reassurogram, essentially. So there's a bit of sometimes you can use it as a bit of a kind of tool to help you. So the player's improving, they've met all their markers, their kind of performance markers, the return to play is great, and then they want to scan, at week 5 or something. At that point, you can, it depends on, you can use it in a different way. But in terms of like from a kind of a purist perspective, I think the dynamic bit does help. It really helps. It helps with ligaments a lot, I do tend to find. And it does help with a lot of the muscle tears because you can test the integrity of it. But for example, again, in that case that I gave, the T-junction tear, that needs, regardless of what it looks like dynamically, a T-junction tear needs to be managed really sensitively and carefully. So it does depend. There's not really a one-size-fits-all answer.
Thank you. So ankle injuries, isn't it best to ultrasound a few days after the injury rather than on the day of the injury?
Depends on what injury you're talking about, but it's not like MRI. So MRI, I think I showed the example of how you get the edema. Now in a hamstring tendon, that's fine, but if it's a fracture, then you tend to get edema. But again, even MRI can pick up these things. But yeah, MRI has got that. There's more to do with giving it a few days, let things settle so you can see things more clearly. It depends on where you're talking about. If you're talking, trying to think through the things. So for example, if you're talking about a soft tissue tear in the ankle, so the Achilles tendon, tib post, whatever, those ones, you don't need to wait. You will see those straight away. You will see the bleeding, but it won't mask your view of the tear. So it's useful for that. If you're using it for like syndesmosis, so you can use a syndesmosis on ultrasound, ATFL. Again, it's actually really good. I've picked up quite a few syndesmosis tears on ultrasound acutely, and you actually see more information because you see the edema. So you have the syndesmosis in the 2 bones, and you see the edema coming out, and you know by the amount of edema that this syndesmosis is not there. So it can actually be a benefit to do it early, and that's what I found in my practice. It's not like MRI that you need to give it some time.
Thank you. So cost implications of MSK ultrasound training and practical experience.
So cost implications. The courses are generally between about 3 and 5.5 grand to go on an ultrasound course. There's, as I said, lots of different ones, but they're generally around that kind of figure. In terms of mentorship, the courses that provide structured mentorship, I think it's about 3 grand for about 6 months of mentorship. Some of them do like one-to-one tuition, and I don't know, you'd have to look at their kind of things, but it's not an insignificant amount of investment. So when you put your training, which is around about 5k, and then you're thinking about getting a scanner, and then you think about mentor, it can cost. So obviously if you can get that funded by your organization, then great, that's even better. But if you're self-funding, then yes, it can add up. Which is why a lot of people try and find mentors through goodwill of NHS staff.
Great, thank you. So the next question is, what is the best way to qualify myself for practicing point of care ultrasound in private practice?
So there are kind of standards. I don't know what the background of the person is, but in terms of the Faculty of Sports Medicine have standards for point of care ultrasound. So it's probably worthwhile having a look at those and to see what standard is there. But generally it is go on a course. The course should be a case accredited course, and you'll get as a minimum like a postgraduate certificate. So that's kind of a minimum benchmark. What was the other part of the question? Was that it? The question?
Yeah, so basically the best way to qualify and myself practicing point of care ultrasound in private practice. So I think you
So it's that, so it's that, and then all the courses will have like a minimum of scans you need to do. So it's usually about 250 scans you need to do. Usually about 150 need to be supervised by somebody who knows what they're doing. So yeah, if you do a course, you'll get that qualification, and then you can just start trying. I think someone's put in the chat, I've just read, that just get practicing, and I completely agree. Just get practicing. But what you shouldn't do, if you don't know what you're doing and you've just gone on a course, you're not sure, is start like making decisions and diagnosing based off of you practicing, which is why I found when I was learning, I was just scanning. But if I thought there was something going on clinically, I almost had to put myself to think, imagine I wasn't scanning this person, would I organize a scan? If the answer was yes, then I would still do it, but I would scan them in the meantime. And then I would make a note. And then when the report comes back, I can then see if I was right about it or not.
Okay, great. Thank you. And so I'm conscious of the time, so I'm going to speed up a little bit. So how early in the, I think we've quite not long gone over this anyway, but I will ask. So how early in the acute phase can you use ultrasound with an injury? And this particular person is usually pitch side. So when a sprain or strain occurs, so how quickly in the acute phase can you ultrasound, which is what we've basically covered.
Straight away.
Yeah.
You can look at all these things straight away. I mean, again, it's like anything, you can do serial. So you could do one pitch side, you can do one, when I say pitch side, dressing room, you can do one next day, day 3. You can see how things evolve. But if there's an injury that's happened there and then, you can generally pick things up straight away for most problems.
Okay, that's great. So what level of evidence is there to support MSK ultrasound guided injections, and training is required to become competent in using MSK ultrasound? I think this is another one we may have answered already, but again, just to reiterate the beginning of the question, what level of evidence is there to support MSK ultrasound guided injection?
It's a good question, because interestingly, I was in a discussion with one of the CCGs recently near where I live, and they were saying, so that the CCG funds MSK to do, or they pay for any procedure that's done ultrasound guided. So they've come back and said there's no evidence to the ultrasound guided injections, so we're not going to fund it anymore. Now, there's so many papers. I mean, level of, I don't know. I can't off the top of my head give you the level of evidence. However, there's definitely a lot of different views about whether ultrasound guidance makes a difference or not. I think the thing, and I've got a really good little infographic on another talk I do about injections, but essentially, if you took 100 people and they all had rotator cuff related shoulder pain, and you all gave them the same management, which was no scan, clinical examination, and then like exercise advice, some didn't get better, you would then inject some of them anatomically guided. Lots of that, a proportion of them would get better. There would be a proportion that wouldn't improve. So those that don't improve, those are the ones where sometimes ultrasound guidance can be useful. There are some conditions, some guided injections where the accuracy makes a difference. So the one that is, for me, was a game changer when I could scan was the AC joint. I remember before I could scan, trying to get in the AC joint. You don't know whether you're in it. You think you're in it. You're squeezing. It's a really small joint, so you're pressing. You think you have to squeeze. I don't know. You really don't know. Whereas with ultrasound, you're in the joint. So from a point of view of accuracy, you don't really need a level of evidence to tell you the obvious, which is that you have absolute accuracy of where you're headed. Now, with something like rotator cuff related shoulder pain, does it matter if you're in the bursa or you're not in the bursa? Maybe it does, maybe it doesn't. For some people, it doesn't. For most people, it doesn't. For some people, it does. So I think having that accuracy can be useful. For some people, it does make a difference. So there might be some people that have had an anatomically guided injection, don't improve. They then have an ultrasound guided one and it helps. There's loads of other confounding factors that can influence that. But one thing that's for definite is the accuracy. The second thing is safety. So, for example, somebody has a ganglion cyst. So I've aspirated a few ganglion cysts that are kind of volar aspect of the wrist. that are wrapped around radial artery. Now, you ain't going to go anywhere near that without guidance. So there's some things that you want to know exactly where you are from a safety perspective. The thing with ultrasound, so for example, when you're injecting the hip, is after you've scanned, you then look for the vessels, and you know that you can check and you can prove that you didn't hit the vessels when you went in. So there's definitely a safety element to it. Whether or not it makes a huge difference from an evidence point of view, there's definitely conflicting evidence out there for both sides of the fence.
Okay, great. So just bear in mind at the time, I'm going to skip to, we have on the live a question and answer. So any other questions that are on the pre-submitted, I will send them to Marwan and ensure he can answer them if that's okay, and then we can obviously follow up with an email after the webinar. But on the live question and answers, we have can you see them?
Yeah, so there's one that says unilateral Achilles. Is that the live question?
Yes, I believe.
Yep, so unilateral Achilles, insertional tendinopathy with no red flags. How do you manage these within the NHS? Part 2, question 1 to answer the above. If they fail physio, what is your next steps in the NHS and privately? So how do you manage this? So how do you manage insertional tendinopathy? It's probably slightly outside the scope of this talk. Obviously, this is about point of care ultrasound. Insertional tendinopathy. I mean, you mentioned no red flags, so obviously you need to make sure it's not part of a rheumatological picture. It's gone. It's disappeared. Well, it's gone to answer, doesn't it? So a heel raise can be useful. Doing kind of loading can be useful for the Achilles. Shockwave is good for the Achilles tendinopathy. So shockwave is a good modality for insertional tendinopathy. So shockwave can be a useful adjunct for Achilles tendinopathy. In terms of if they fail physio, NHS and privately, so shockwave would be a next. So if you were, let's say they had all the education, teaching podiatry or footwear assessment and all that kind of stuff, lots of loading, dealt with any other factors. So again, thinking outside the box in terms of Achilles problems, have they got a history of lots of antibiotic use? Have they got a history of gout? Other stuff that could cause Achilles problems. Have they got a high cholesterol count? A lot of these things can deposit in the Achilles. So thinking a bit wider. But then if I was going to go more on like the ladder approach, shockwave is good. So some NHS services that I work in have shockwave, some don't. So if you've got it, I would do it. And then after that, if you're really at the end of your tether and you're not getting anywhere, then a small load of steroid injection into the retrocalcaneal bursa can often settle these down really quickly. So I don't really have a different approach NHS and privately. It's exactly the same, and that's with anything that I do. It's the same approach. Just depends on resource really and what's available.
Okay, great, fantastic. So just coming to the end of the webinar now, Marwan, I just want to thank you so much for your time this evening. It's been absolutely fantastic. I know that you've had an eventful few days, so thank you for giving your time to us. So following that, so thank you all for joining us this evening, and we hope you have enjoyed the session. Following this, you will receive a survey along with a link to the webinar recording. We would really appreciate your feedback and any suggestions for future webinars. You can visit the Physical Academy website, where you can find all of our past webinars and other educational resources. Otherwise, thank you once again, and have a good evening.
Thanks, everyone.
Thank you.